Order. Welcome to the Public Accounts Committee on Monday the 22nd of June 2020. Today we're considering work that the National Audit Office has done on the preparedness of the NHS and social care sector for the peak of Covid-19. And I want to put on record the committee's thanks to the witnesses and the organisations they represent for the enormous amount of work that has gone into preparing for the Covid-19 peak. But we know that the first case of Covid-19 arrived in the UK or was diagnosed at the end of January. The National Health Service announced its strategy to combat the outbreak on the 17th of March, and a plan for social care followed in the middle of April once we'd already locked down. That included, of course, the Nightingale hospitals postponing non-urgent operations, testing, supporting those discharged from hospitals into care homes, and trying to tackle the challenging issues around providing personal protective equipment, of which the stockpile that was originally there ran down as time ran on. So we want to hear from the officials who are in front of us today how the government, how that coordination for dealing with it worked, what lessons were learnt, what new measures have been put in place since those first plans, and what you're doing to plan for a potential second wave of infections. So I'd like to welcome our witnesses today. We have Sir Chris Warmold, who's the Permanent Secretary at the Department for Health and Social Care. Sir Simon Stevens, the Chief Executive of the National Health Service. Amanda Pritchard, the Chief Operating Officer for NHS England and NHS Improvement, or NHS E&I, as it's sometimes known. Rosamond Roughton, who's the Director General for Adult Social Care at the Department for Health and Social Care. Catherine Francis, who's the Director General for Communities at the Ministry of Housing, Communities and Local Government, representing her accounting officer as well as herself today. Professor Paul Johnston, the National Director for Place and Regions and Deputy Senior Responsible Owner for PHE COVID-19 Response at Public Health England. And Professor Steve Powis, who's the National Medical Director, who's recognisable to everybody from the 5 o'clock briefings, as are many of you. Can I thank you all for coming? We won't be hearing from all witnesses on every question, but I wanted to welcome you, as I say, and repeat our thanks for the hard work you've done. But we do now need to be reassured that you've learnt lessons about what didn't work, and hopefully will acknowledge what hasn't worked as well, and answer questions from us about how you're preparing for the next stages. I'm going to, first of all, when the bell has quietened down, ask Peter Grant if he'll just come in on what's happening in today's news. Mr. Grant, over to you. If you could unmute.
Thank you very much, Chair, and good afternoon to all of our witnesses. It's been widely trailed by the government that the Prime Minister will tomorrow announce a reduction in social distancing requirements from 2 metres down to 1. Is it the intention of either the Department of Public Health England to publish a risk assessment at the same time so that we know that the government can be held to account for its management of the inevitable risks that will follow on any reduction in social distancing?
To Mr. Grant.
Sorry, Sir Chris, I don't know if Professor
Sir Chris wants. Sir Chris,
yes, I'll take it. I'm afraid you will have to wait for what the Prime Minister says and do in accompanying it. I don't think it will surprise you that I'm not going to preface anything that the government might or might not announce in future. On your general point, it's of course very important that we're held to account for everything we do, as we are at this hearing, as we are through NAO reports and otherwise. So I agree with your general point that the government has to be transparent and accountable, but I'm not going to say anything further about what the government might or might not do in the coming days.
Does Professor Powis want to come in on the wider issue about the difference between 1 metre and 2 metre? Professor Powis. Who's muted? Sorry, Professor Powis is muted for some reason. Can we?
I've unmuted myself.
Oh, thank you. Thank you.
That generally worked. No, I don't think I would want to add anything more to what Chris has said. Clearly, as has been reported, SAGE has provided advice based on the as summarised the scientific evidence, but it's for government then to, as in all matters, to decide policy.
Professor Powis, we've heard a lot about the government relying on the science. Do you think that it's always categoric science, or is it often a matter of judgment?
Well, the job of SAGE is to assess scientific evidence and to provide advice on the basis of an analysis of that evidence, and also to point out where evidence is not strong, and occasionally to help with the seeking of new evidence where evidence is required.
Okay, well, thank you. Peter Grant, did you want to add anything else?
Thank you, Chair. For the avoidance of doubt, I'm not asking Sir Chris or anyone else to tell us what's going to be in the Prime Minister's statement. I'm just asking for an assurance that, given that it's the job of Parliament to hold the government to account for the way in which they follow the science. We can only do that if we get told what the science is, not necessarily before the announcement is made, but as soon as possible afterwards.
Yeah, and of course the government has been publishing the advice it has received from SAGE, but just to emphasise Professor Powis' point, SAGE advice is exactly that, it is advice. It is then for ministers quite properly to balance that advice against their wider view of the public interest and take decisions accordingly. And I mean, and just to state the obvious, science does not deal in categorical yes-nos. It is quite clear that there is very little difference between 2 metres and 1 metre 99. There is not a yes-no answer to a lot of these questions. As you see when you read the science advice published by SAGE, it sets out a series of balance of risks, and then as is perfectly proper, ministers weigh those balance of risks and decide where the public interest lies.
Thank you very much, Sir Chris. I'm going to go to Olivia Blake now. Olivia Blake, if you could unmute yourself. Thank you.
Thank you, Chair, and thank you to all the witnesses for your time this afternoon. Firstly, I just wanted to ask a couple of questions about the NHS volunteer scheme. I just wanted to ask Sir Chris Wormold and perhaps Simon Stevens as well about what the costs to the department were of the NHS volunteer scheme, and if you feel that this is value for money.
Sir Chris Wormold.
Sorry, I don't actually have that number with me, and I don't think it's in the NAO report. I don't know if Simon...
So Simon Stevens, could you unmute, and if you forgot the figure, that would be helpful. So Simon, you need to unmute. So there's been a change, which I wasn't aware of, that actually everyone's pretty much muted, except for some reason Sir Chris Wormold. But so Simon, if you could unmute yourself, please. So Simon, you need to unmute yourself. Sorry, there's been a change. Yeah, thank you.
Sorry, can you hear me?
We can hear you loud and clear, thank you.
Okay, thank you. Yeah, sorry, it was right. Well, the point of the volunteering scheme is that although you need to put an infrastructure in place to support it, by definition, volunteers are giving of their own free time, and the support that the Royal Voluntary Service has provided to more than 600,000 volunteers who have stepped forward has been magnificent. In terms of the grant that the RVS and others are getting to support that volunteering, happy to write to the committee, but I think the key take-home is that this has been a overwhelming response by the public, and those volunteers have been useful not only, for example, in delivering medicines to people at home, like the pharmacy scheme I saw in Brixton on Friday, but also in supporting a much wider range of public services as well. And it may well be that if you have colleagues from DCMS or the Ministry of Housing and Local Government, they want to chip in, because part of the shielding support that people have been getting has also relied on volunteers.
Olivia Blake.
Can I ask 2 follow-ups? Is that possible? So I just wondered how many of the 600,000 people who signed up were actually deployed as volunteers, and also if Catherine Francis thinks that this could have been better organised and perhaps better value for money if it had been run through the MHCLG hub scheme.
Is the first one to Sir Simon, Ms Blake?
Yes.
Yeah, my understanding is that to date over 300,000 volunteering tasks have been completed, and progressively the range of people who can request help from a volunteer has expanded.
Perhaps I can
Catherine Francis.
Perhaps I could come in on the issue of local authority hubs. Local authorities have been able to access the central NHS volunteering mechanism, like other organisations and like other charities also in their area. So it's been an additional resource for them to use, and they've made good use of it. But it hasn't supplanted other organisations that are operating locally as well as you'd expect in individual areas where they may have support networks and charities that work in each part of the country as well. So it's been an effective additional string to their bow.
Ms. Blake?
So do you don't think that the infrastructure that local authorities have around this sort of work would have been quicker and probably more successful at getting volunteers on the ground quicker?
I personally don't, because I think this is both and in the way that Catherine has described. And local authorities have had the ability to task the volunteers who come forward with helping in their areas. But I think the reality is a lot of people responded because they wanted to help the country and they wanted to help the NHS at the time of coronavirus. And doing so in a nationally coordinated way meant that we got far more people coming forward than we've ever seen at any volunteering opportunity in the past. That is not cutting across the work that people like St John's Ambulance, the Red Cross, Age UK have also been doing together with local volunteering networks.
Ms. Francis?
I don't really have very much to add to that. I think that the 132 hubs across the country have made use of what is available to them. In some cases, quite rightly, that is a very localised set of volunteers, depending on their local area. But in many, many areas, they've accessed either local volunteers or other organisations via the centrally organised scheme. I don't think it's for us to say centrally which would necessarily have been the best combination of those things in each place.
Ms. Blake?
That's all, Chair.
Okay, can I just ask Ms. Francis on whether we've had another letter from your department about the money available to local authorities. We'll be pursuing it further in writing. It didn't give much more information. Was the money provided to local authorities specifically to deal with the number of volunteers? Because some had large numbers in their own area and then were asked to absorb a number of the national volunteers, which was quite a big job going through the checks and allocating tasks and keeping people in play. Did they get any additional funds specifically for volunteers?
The shielding local support that councils had to give, both to corral any volunteering efforts or support for individuals, contact to individuals, was one of the areas of expenditure which was part of the £3.2 billion that we expected councils to meet from that allocation. And some of the material that we've published this weekend about how they've spent that funding has set out the allocations that the money that they've used on shielding locally.
So there's nothing specific. What you're saying really is there's nothing specifically for managing the volunteer hubs locally. It was they could or couldn't or could, if they wanted to, take it out of the 3.2 billion, their share of that.
Exactly, the 3.2 billion was there amongst other things for that purpose.
Okay, so because it's been quite costly, I know, for some boroughs. But I'm going to move on because we've got a lot of ground to cover around the very vital issues of what was happening in adult social care in our care homes during this. As I highlighted, the plan for social care followed a month after the NHS plan, which I'm sure reasons that you will explain, but it would be helpful to find out more about this. And I'm going to ask Sir Geoffrey Clifton-Brown to unmute and lead off on the questioning about adult social care. Sir Geoffrey, over to you.
Sir Chris, good afternoon. As the Chair said in her opening remarks, the first case of COVID was reported on the 31st of January. The NHS declared a level 4 incident on the day before, on the 30th of January, and yet proper guidance wasn't given to the NHS and its hospitals until the 17th of March. What was going on between the 2 days?
With the NHS?
Yes. With the NHS, yes.
With the NHS. So, well, I'll ask Simon to comment on that. But in general, and this goes for both the NHS and social care, the action plans that we published were not the beginning of our activity. And we were issuing guidance and in dialogue with both sectors way before we were formally publishing guidance. But I'll ask Simon to comment specifically on the NHS point.
Yes, good afternoon, Sir Geoffrey. So, as you say, on the 30th of January, we declared a level 4 national incident, which is the highest level of emergency response that the NHS can provide, and that was coincident with the World Health Organization declaring on the same day a public health emergency of international concern. The next day, the 31st of January, we were preparing to receive, if you remember, the repatriation flight of people to Arrow Park Hospital on the Wirral. On the 3rd of February, we opened our Incident Coordination Centre for London, given that we could see that there was likely to be a heavy impact there. On the 6th of February, we began weekly briefings for NHS clinical directors and leaders on the COVID response, webinars. On the 7th of February, we wrote with the Department of Health and Public Health England around the case definition and the handling of suspected cases. On the 10th of February, we commissioned extra high consequence infectious disease capacity. On the 18th of February, we strengthened the national oversight. On the 2nd of March, we sent the NHS preparedness and response letter, followed then, as you say, on the 17th of March and the 19th of March with more detail. So I think it would be wrong to start the chronology on the 17th of March because, as I think I've just demonstrated, the prior 6 weeks, we were also heavily sleeves rolled up preparing for the impact of coronavirus.
Sir Geoffrey.
That's very helpful, Sir Simon. I want to just come back to Sir Chris, and then I'm coming back to you after I've had one question with Sir Chris. Sir Chris, you sent out Sir Simon sent out very clear advice on the NHS on the 17th of March. It wasn't until the 15th of April, some 7 weeks later, that proper advice was sent out to the care sector. Wasn't the care sector throughout all of this very much the forgotten cousin?
No, not at all. And I'll ask Ros in a moment to set out what we had done with care before the action plan was published. But as a general point, this is both a situation and a disease which we are learning about and were learning about the entire time. It is not a situation where government can issue a single piece of guidance, and that is that. So in both sectors, it was a building picture over time, and as we learned more, we advised more. Now, there is no, I don't agree that we left out social care. We did a lot of work with social care over this period. However, and as I think I said at the last hearing that we did on the 22nd of May, it is clearly more challenging for us to act in the social care sector given its fragmentation than it was in the NHS. So I'm not going to deny that it was considerably more difficult for the government for the actions that it took in the social care sector due to the nature of the sector, but I don't agree that we in any way left it out. But Ros, would you like to set out the actions that we took?
Ros Roughton.
Thank you, Chair. Yes, so we began work on this well in advance of the 15th of April action plan to which you referred. So on the 25th of February through Public Health England, we set out advice for people working in residential settings. And on the 13th of March, we issued guidance both to residential care settings for home care provision and for people in supported living environments. And that marked the change from the contain to delay phase of the pandemic. And that guidance both gave advice to care home providers about what they could do, but it also set out steps that the NHS would take to support care homes and steps that local authorities would take to support care homes. And we followed that then with the fundings through to local governments, working with colleagues in MHCLG and the Treasury on the 19th of March, and then with the beginning of the first issue of PPE from the pandemic flu stock the following week. So there are a number of steps we took in advance of the action plan being published on the 15th of April.
Sir Geoffrey.
Sir Chris, I would say far from building your policy on the emerging disease, you didn't give that advice on the 15th of April to care homes until the pandemic was almost at its peak at the end of April. Wasn't that, wasn't that pretty actually negligent, really?
No, I don't agree with that at all, for exactly the reasons that Ros has just given. Were that action plan the first thing we had done in the care sector, that would be one thing. But as Ros has just set out very clearly, there was considerable advice and considerable investment in the care sector before that day. And I would return to the beginnings of my answer. This isn't a situation where you publish an action plan on a day and that is that. The action plan we published was the bringing together and the enhancement of a lot of advice and support we had been putting into the sector already. And as Ros has just set out, the department started action on this considerably before the action plan was published.
So, Sir Simon, 2 days after his advice on the 17th of March, advised NHS hospitals that all patients that were clinically fit to do so should be discharged, presumably most of them to care homes. The care homes on the 2nd of April were asked to ramp up their capacity to take these people. That was reinforced, and I know it was, in Gloucestershire, by the local authorities pressurising care homes to take people. If an individual care home wouldn't take them, they would find another care home that would take them. This was at a point where the testing was at pretty well zero. 5 people per care home were allowed tests at that point. They hadn't got adequate PPE. There wasn't adequate testing. They didn't have adequate training at that time. How can you say this wasn't negligent?
Sir Chris.
So I thought he was aiming his question at Sir Simon.
No, you're responsible for the care homes. Sir Simon is responsible for the NHS.
Yeah, well, we'll set out the position on discharge, and I think Professor Powis is actually going to lead off on that, and then Ros will add.
Could you, Professor Powis, also cover the fact that there was pretty little testing when these care homes were being asked to take these patients from the NHS hospitals?
So I think there's a number of important points to make. So firstly, of course, at that time, which was the first few weeks of March, the numbers of cases in the UK, identified cases, was not, as you said earlier, high. That was at the start of the epidemic in the UK, but we could quite clearly see from the modelling that was being undertaken that there was very likely to be a very large increase in the number of cases that the UK would see. The modelling predicted that many thousands and indeed hundreds of thousands of patients in an unmitigated epidemic, in other words, in an epidemic where measures weren't put in place, would occur, and that would overwhelm the NHS. I think the figure in the NAO report talks about an 8 times greater than the capacity we had in intensive care beds. And in our general beds, we have around 100,000 general and acute beds in the NHS normally. It was clear from the reasonable worst case scenario that SAGE were working on that the NHS would quite simply be overwhelmed by the epidemic that we were looked as if we were facing. And of course, at the same time, we were seeing health systems elsewhere in Europe being overwhelmed.
Can I just stop you there? Can I stop you there, Professor Powis? Can I just stop you? Isn't it the case that all along this policy was driven to stop the NHS being overwhelmed, and there wasn't the same degree of care, if I can put it that way, for those being the care homes who had to deal with these patients?
Well, the first point I was making was that don't underestimate the potential effect on the NHS. And of course, many of the patients that we now managed over 100,000 patients with COVID in the NHS. And many of those, of course, are elderly and vulnerable patients who have unfortunately caught COVID-19. But the second point, and I think you said it yourself in the introduction, was the ask was to discharge people who were clinically fit to be discharged. So we always wish to discharge individuals who no longer need to remain in hospital. So this was the discharge of those whose medical treatment work was complete.
But I'm sorry to interrupt you again, Professor. I'm sorry to interrupt you again. But how did you know that they were clinically fit to be discharged and they didn't have COVID? Because you didn't test them, did you?
Well, because there are processes in place in hospitals to ensure that people who no longer require medical treatment in hospitals, and that includes people such as this, would be discharged. So that's always been the case, that we would want to discharge people who are clinically fit. Of course, in the elderly, staying in hospital when you are medically fit for discharge can be harmful. I've spoken about that in the past. I've written about it in the past.
Then check.
It's always our aim.
So, Professor, so Geoffrey,
Professor, you haven't answered my question. How did you know they didn't have COVID or when you discharged them? Because you didn't test them.
Well, we were following the testing advice that PHE had provided at the time. So they were discharged according with PHE policy on testing at that time. And indeed, remember that the vast majority of people who have caught COVID-19 in the UK have not been treated in hospital. They have been managed, or they have managed themselves.
Professor Powis, can I just chip in there? I mean, you said that they shouldn't be discharged from hospital unless medically fit. So are you saying that the hospitals should have tested people for COVID-19 before release in order for them to be clear that they were medically fit for discharge? Is that what I'm reading?
No,
into what you're saying?
No, because we followed the guidance on testing that was extant at the time.
Right. Okay. I just wanted to be absolutely clear on that. So Geoffrey, the
point I was making is that the vast majority of people who have contracted COVID-19 have not required hospital treatment. So it is wrong to equate hospital care and treatment with infection.
So Professor, page 11, paragraph 15, it says very clearly that this is in the care homes, peaked at just over 1,000 homes per week in the first week of April. This was the very week that the NHS had told care homes to ramp up their capacity to take patients being discharged from hospital. So you already knew there was a considerable problem in care homes. You were discharging patients into some of the most vulnerable people in society. Surely this was just absolutely reckless, wasn't it?
Well, as I said, we were following the testing strategy that was extant at the time, and I'm sure Professor Johnson will be able to come in and describe the testing situation at the time, which of course being led by my colleagues at PHE.
Well, let's hear from Professor Johnson.
Good afternoon.
Good afternoon.
So the available tests nationally at the time were around about 3,500 tests a day, and in agreement with the NHS and with the CMOs and the devolved administrations, we categorised 3 types of situations where tests should be deployed given the limited number of tests. That included very sick patients on ITU, other patients in hospitals that needed a differential diagnosis who had a respiratory infection, and testing in care homes to diagnose outbreaks, and they were the 3 top categories for testing.
So Geoffrey.
So Chris, you were discharging them from hospital into care homes when care homes were already in dire trouble. Some of the most vulnerable people in society, the testing wasn't available, the PPE wasn't available, the training wasn't available. Wasn't this a pretty reckless policy by the government?
No, for the reasons that my colleagues have described, we don't believe that. Now, as Professor Powis described, at this point, COVID was not considered to be widespread in the community. We knew we were going to get into hospital a large number of COVID patients. And
so Chris, I'm sorry to interrupt you, but I must just come back to this point in paragraph 15. At the beginning of April, just over 1,000 homes had already had cases of COVID, so it was clear there was an emerging problem in the social care sector.
No, sorry, just to be clear, at the point when the NHS issued its guidance on discharge, that was before the period that you're talking about. And as I say, I am not denying that we had challenges in care homes. On the specifics of discharge, the NHS advice, as you described it, was earlier. And at that point, we were, COVID was not widespread.
Now look, I'm sorry, Sir Chris, I'm going to have to stop you again. Because paragraph 3.19 on page 47 makes it very clear that on the 2nd of April stated that care homes needed to make their full capacity available, that they could admit patients with COVID-19. So you were sending people from hospitals in quite large numbers into the care home sector, which you knew was already facing a substantial and increasing number of COVID patients of their own. They didn't have sufficient PPE, they didn't have sufficient testing, and they were the most vulnerable group in society. How could that have made any sense whatsoever?
Well, for the reasons that Professor Powis sets out, you do not want to keep in hospital patients that are clinically fit for discharge. Now, in the way that Ros Roughton described earlier, we were putting in a range of protections in care homes. But as Professor Powis has set out, what you don't want to do is keep people in hospital, which we knew were going to receive large numbers of COVID patients and would have infection challenges of their own, people who didn't need to be there. Now, in terms of the care homes outbreak, and Professor Johnson and Ros may want to say more about this, the clearest correlations we have between social care outbreaks and other issues are related to staff, not the admission of residents into care homes, and that's been one of the big focuses of policy for us. Now, as I said at the beginning, we are not disputing, and no one would, we have had huge challenges in care homes. We've learned an enormous amount about this disease and how to deal with it, and we have made considerable progress so just for the avoidance of any doubt, I am not here to say that there were not big issues with care homes, and that we have learned a lot and we need to do more both now and in future. That is all common ground. What I am saying is that the decisions that we took around discharge, which were all based on clinical advice at the time in the way that Professor Powis and Professor Johnson have described, were rational given the evidence that we had on the table at that time. So, as I say, I'm not denying there were big problems, but I don't accept the reasons that the two professors have set out, that the decisions were not soundly based in science at the time.
So can I move to you, Professor Johnson, and talk about testing? What was PHE and NervTag doing between the 31st of January and when the tests were altered to just 2 people in care homes? Why did it take so long to get the testing regime ramped up to a level that not only would cope with the NHS, but also cope with care homes as well?
So thank you, Sir Geoffrey. If I can just make it clear that PHE run a specialist reference laboratory, which are not the large-scale pathology laboratories that were needed. But what we did do is very early on in late January, we were able to identify the recipe for a test, working alongside international scientists at WHO, and we, as a result of that, we were able to distribute this recipe so that by the end of March, 40 NHS labs could do that, could test for COVID-19. That is the fastest deployment of a test in the UK that we've ever done. And the wider testing strategy, which the government announced in in April was about bringing in other players to ramp up the testing. So we achieved the target of what we call Pillar 1 tests. It's the swab tests and the remaining tests, which is led by DHSC, they call Pillar 2 tests, the driving tests and so on, was also ramped up during April. So from PHE's perspective, we did what we were we did more than what we were asked to do. We worked internationally, we got the recipe, we deployed it, we got the tests out to 40 NHS labs, and we supported the Lighthouse, the Mega Labs programme as part of the national testing strategy led by DHS.
Which we know. Thank you for that. Sir Geoffrey.
So Chris, paragraph 3.16 on page 47 says in the period up to the 5th of April, a maximum of 5 symptomatic residents in care homes would be tested. Given that you were discharging all these patients into care homes, could you not have prioritised the care homes to get a little bit more availability of the tests that were available, given that it was limited?
Well, again, we acted on the clinical advice that we had at the time. I mean, the NAO report sets this out extremely clearly. So the figure 2 on page 17 of the NAO report shows the build-up of our testing capability. As is clear, particularly during March, in that early period, our number of tests was quite limited. And much smaller than we would have wanted, as the Chief Medical Officer and others have made clear. Now, within that limited capacity, we took clinical advice on where that capacity was best deployed, and it was I think Professor Paris has already said this out. Top of the list came to people who were in hospital where their treatment depended upon a COVID diagnosis. Stephen might say more about this in a moment, and that was our top priority. And we had a priority for care homes, but our capacity was limited. So, as I say, we acted on clinical advice on how to use our limited capacity. But again, I'm not here to be defensive. That we will want and have learned from our testing experience, and it's one of the areas that, as the NAO report sets out, we have evolved most over the period of this terrible epidemic. So that's the rationale for the decisions we took at the time. It became clear to us, as you know, that ramping up testing was an absolute priority for the management of the disease going forward.
Yes. We've got the gist of that. We've got the gist of that.
Sir Geoffrey.
But up to the 5th of April, it was limited to 5 patients in care homes that were showing symptoms. There was no thought, was there, for giving testing to the staff in care homes who had limited PPE, limited training, and no testing?
Well, that's not exactly true, and I'll ask Ros to set out the position on testing care homes. The reason for 5 was basically, once you've got an outbreak in a care home, you know you have to go in and do infection control and all those sorts of things. Knowing that there's 10 rather than 5, well, if we had the capacity, we would clearly have wanted to do that. But once you've got 5, you know you've got an outbreak. So the actions you then need to take in that care home aren't dependent on future tests, and that's why it was done in that way.
No, but Sir Chris, the question was about the staff, not the patients.
I was simply explaining the 5 as you had raised that question. I'll now ask Ros to comment on staff testing, which we also ramped up. Ros.
Yeah, so as other colleagues have said already, we had limited testing capacity at the start, and as that grew, we made more testing available both for residents but also for staff. So as soon as we had the facility for the kind of drive-in testing, we opened that up to all care staff. because that was spread out across the country, we got a lot of feedback about the difficulties for some staff in accessing that. And as a result, as when we've got even more testing capacity, we have been able to send out test kits now to every care home across England that has ordered them, for them to test all their staff and all their residents. So as our capacity has grown, we have been able to test more and more people.
Thank you. Can I change the subject now and come to Catherine Francis? Catherine Francis, can I ask you about the additional 3.2 billion funding you gave to local authorities? Will this be sufficient to enable them to properly ensure the sustainability of the care home sector?
Well, thank you. I mean, the data we have so far, we've spoken about in an earlier hearing. We've put £3.2 billion into the sector. We have not, your question is about social care, we have not ring-fenced that for social care, and the reason for that is because we think that local decision makers are best likely to know their own market and to know where it's needed most. We have urged councils to prioritise social care spending, and the monitoring returns we've got in show they've spent just over 500 million on social care from this funding. That's in addition to other funding that's gone into the system, such as the infection control grant. So we've asked councils if they can consider increasing the fees that go to care home providers, putting cash payments up front, and we've now asked them to publish data on their websites of the support that they offer care homes in their area. So far, the data is showing, as I say, that they spent £500 million on social care, and that in aggregate, the council sector has spent 1.25 billion of that 3.2 billion overall on all spending.
But given that you provided that 3.2 billion, you've also provided an extra 600 million for infection control. Are you satisfied that they've only managed to spend 500 million so far out of what, sort of 3.7 billion?
Well, I think they're for slightly different purposes. So the infection control grant that has gone in is for exactly that. It's for infection control in care homes, and there are quite specific conditions on councils to try to get that funding out as quickly as possible and pass a large chunk of it on directly to care homes. Ros Roughton will be able to comment on that. On their expenditure, I mean, social care so far, adult social care, is the largest portion of councils' expenditure from the money that they've spent so far. They've spent 1.25 overall, and 500 million is on adult social care. Given that they have not yet spent all the money that they've been given, I think we don't necessarily have any evidence that it is not enough funding that's gone into the system, let's put it that way, but we are keeping it under constant review, and we have said that we will come forward with a plan for council's funding for the whole year very shortly. But our priority has been to get the money out to the sector and to urge them to use it where their local market conditions suggest to them they should best be using it.
So Geoffrey.
So Chris, I'm sorry, I was rather brutal on you earlier because the care homes sector does upset me. I can be less brutal on the funding. How many care home providers are at risk of failing, and how much capacity are you risking losing?
Well, I'll ask Ros to answer that. On your first point, which is very kind of you, I would say, we challenge ourselves on social care every day as to are we doing enough? So we don't we are not attempting to avoid scrutiny, and your questions are exactly appropriate.
Well, we don't need to. We cut the niceties, perhaps, and cut to the chase. Thank you.
Ros, would you like to answer the specific question?
Yeah, so if I can just pick up the previous question about the funding and then come on to provider viability. So just on the funding, the feedback that Catherine referred to won't yet include £600 million infection control fund. So I would expect that for us to see in future data coming back through MHCLG, that also will be spent. And to say that first tranche of funding, the Secretary of State for Health and Social Care did write out on the 19th of March to local authorities setting out some of the things on which that could be spent, and that did include some things like helping providers to meet costs associated with enhanced infection control and protection of staff. So it's important to see the infection control fund as something that was additional. It wasn't the first tranche of money that local government got to help with infection control. On the provider viability point, Sir Geoffrey, that you asked about, so as you'll know, in adult social care there is an open and competitive market, and has been for more than 30 years. And we do know that there is both increased costs on that market, which is why we are providing extra support, and also impact of reduced demand in some parts of the sector. So we are seeing a little reduced demand for care homes, but we are seeing in other parts increased demand. So it's different circumstances for different care providers. For the large providers, we do have a well-established, tried and tested regime for monitoring that through the Care Quality Commission's market oversight regime, which looks at the 25% sort of biggest providers in the market. For the smaller ones, we are looking very closely at the evidence base. We are getting submissions from the care provider associations to make sure we've got the clearest possible understanding of the kind of uncertainties and challenges that are posed by COVID. And we will, we're working with local authorities at the moment to look at how we get the balance right between supporting providers and then and supporting people when care providers do go out of business, which every year we do have a flow of entry and exit from the market. So,
yes, which we've covered in previous reports, which is we'd love to get into more today, but I think we need to move along. So, Geoffrey, we do need to. No,
I'm finished, Chair. Thank you.
Thank you. Just to highlight, Ros Rowton, that we have looked at this. The Department's management of the care market, supply of medicines for Brexit. And for care homes, and so we'll be touching on a little bit of that a little later. I'm just going to bring in Gagan Mahindra, followed by Nick Smith, and then Richard Holden. So, Gagan Mahindra, if you can unmute. Thank you, Mr. Hindra MP.
Thank you, Chairman. Can I firstly declare that I am a councillor, just for the record? Just going back to the stress test for care homes. There is a perception that the social care side of the department is not treated as well as the NHS. Could I get your views on that statement for Catherine Francis? Oh, sorry, not Catherine Francis, for Ros Rowton.
Ros Rowton.
Thank you. Well, I believe that I've had all the support that we require from across the department and partners across government, and indeed the support we need working with local government and the care sector to deal with this. But as I think Sir Christopher said at the start, this is a different context from the NHS. You know, unlike the NHS, we're talking about thousands of small independent providers with a mixed funding model, and that's made it a very challenging and tough context for responding to COVID, which is different from the way in which the NHS operates.
And for Sir Chris, we've heard a lot about the evidence base determining decision making. Do you think there was sufficient data to drive some of the clinical decisions put forward by PHE and your own officers?
Would we have wanted, well, there are several ways of answering that question. Would we have wanted more data and more information about the disease when we took decisions? Undoubtedly, yes. One of our huge challenges is, of course, this is a very new disease, and at the beginning of the outbreak, we were in a position where we had to take decisions for many of the reasons that Sir Geoffrey was setting out on the basis of imperfect knowledge. And we are still acting on the basis of imperfect knowledge. Some absolutely key things, particularly around things like the role of asymptomatic patients and the level of immunity that you get from having had COVID, are still medical and scientific unknowns. So we were undoubtedly in the position, and I think I said this in one of the answers to Jeffrey, we were in a position of needing to take decisions on the best evidence that was available on that day. That was the right thing to do, but I wouldn't at any point claim that was perfect information. The other thing I would add, and it emphasises something that Ros has just said, is it's simply a statement of fact that we have much better information and much more timely information in the NHS than we do in the care sector. That's due to the structure of how those two things
but also
are
Mr.
done.
Mahindra.
So Chris, wouldn't it also be the case that the fact that more testing was done in NHS and within hospitals rather than within care homes has inadvertently meant the data was better on the NHS side rather than the care homes?
Well, as I say, the decisions about how to use the limited testing capacity that we had were based on clinical advice. And just as a statement of fact, of course, the people who need testing most were people being admitted or in hospital who were showing symptoms that might or might not be COVID. And that was at the top of our priority list. That was a clinical priority, and in my view, the correct one. As we set out in previous answers, we were testing in care homes. That was one of our priorities, and as Ros described, as our testing capacity increased, we have massively increased the level of testing, both of staff and residents in care homes.
Mr. Mahindra.
So, yeah, can I direct my question to Professor Paul Johnston, because so Chris and others have said that it was based on PHE guidance. Obviously, there was a limited supply of testing. Did you feel you had sufficient information to ensure, to make the judgment call, and it would have been a judgment call, between frontline NHS staff and patients versus those in the care sector?
So I would like to answer the question about whether we have sufficient information about tests for outbreaks in care homes. When it comes to the difference between waiting between NHS and social care, perhaps I'd like to pass that back to Chris. But in we have been operating for years, supporting outbreaks of all infectious diseases in care homes. Our local health protection teams know the care home sector. And in COVID, as in previous examples like norovirus outbreaks or seasonal flu, the care manager, on suspicion of an outbreak, would phone the health protection team, and the health protection team would arrange those 5 tests that we've heard about. That 5 is about being clear about the diagnosis, and from that, PHE local teams would provide advice on infection control, on isolation of patients if needed, on the correct PPE, and general cleanliness and disposal of waste. So I think we have sufficient data and information to manage those outbreaks in that real time.
Thank you. Can I just ask Mr. Mahindra if you could just lift his head a little, move his screen, because we can only see the top of your head, Mr. Mahindra, some of the time. Thank you.
So, thank you. So just going back to Sir Chris, hospitals got a stress test before the peak in infections. Why did this not happen in adult social care sector?
I'm not quite sure I understand the question.
It's about stress testing. This was done in hospitals before the peak in infections, but it didn't seem to happen in the care sector. Just want to know your views on that.
Well, I'll ask Ros to comment, but we've set out already at this hearing the measures that we took in care homes and why, which, given the differences between the sectors and our leverage in them, we felt at the time was commensurate with the needs in the two sectors. But Ros, would you like to add?
I think the only thing I would add is this is also, I think, a reflection about the different context in which we've got a local government role and a national government role in the care sector. So many local authorities will have stress tested their business continuity plans, and indeed over the past year there's been quite a lot of work done on that anyway for the care sector, because in respect of leaving the European Union. So I think what we were getting ready for was if there was going to be a surge of demand, so that we had the data around capacity, if we needed to get more capacity in the care sector. And that had been the planning that we'd done in from pandemic flu planning. That had been one of the things that had been highlighted that we might need to be thinking about. So I think that what I'd say is what we don't have is oversight of what every local authority and the NHS may have done at a local level in terms of testing those plans.
Okay, well, I think the frustration that we've had as a committee is that there's perception that we don't have all the data to ensure that we can actually measure the impact of your decision making. I know there'll be subsequent NEA reports to do with PPE and the like, and hopefully that will flesh out some of those concerns that I personally have at the moment. The system at the moment seems to be a twin track between the NHS and social care. In hindsight, do you think it should have been a system-wide approach, incorporating both care homes and adult social care and the NHS?
So, Chris.
Yes, I'll start on that. I mean, just as a statement of fact, as this committee well knows, there are significant differences between how the NHS is run and how social care.
So, Chris, we do. I think we need to cut to the chase, as we do know that as a committee, as you say. So, can we cut? Perhaps you could answer Mr. Mahindra's question.
Yeah. Now, in this crisis, we have taken a more national and more interventionalist role in social care than we ever have before. And there has been actually a considerable amount of excellent working between local government and the NHS to deal with the issues that are arising. So we cannot get round the fact that these are very different sectors with different statutory bases, and one's a public service and the other is a number of independent providers. So the approach we took was certainly to look across the piece at what did we need to do to fight the infection as a whole, and then to be considerably more interventionalist, both in terms of funding and guidance and intervention than we ever have before on social care, while promoting joint working between social care and the NHS, which, as I say, we've probably seen more excellent joint working between local government and NHS.
It's not quite that. We're talking about the specifics. Mr. Mahindra was particularly asking about a system-wide approach more generally, and we've talked to you twice before, at least to my memory as chair of this committee, about your role in shaping the market for social care, in your role in supplying medicines if there was a Brexit no deal, and we've been looking at this issue. So there are three areas where, as a department, you would acknowledge there's been a divide between what's happening in social care and what's happening centrally and nationally through our NHS. I mean, we could list some others as well.
I've never denied this, and there are services which, as you know, operate on a different funding basis and a different statutory basis. What I'm saying is that actually those divisions over the last 5 months, while we've been dealing with this set of questions, have been considerably less than previously. I'm not going to claim that we run them as a single national system, because clearly we can't. But we have pushed the limits of what we are able to do in terms of bringing the two together.
Mr. Hindra.
Thank you, Chairman. So just going back to my earlier question about the stress testing to do with care homes, you correctly pointed out, Sir Chris, that this is a very fragmented market. Wouldn't a stress test allow you and other policy makers to realise where the weaknesses were in the system and what intervention was required? Because you've intervened in certain points within the system, but not others. Yes. And we're just trying to get a clear rationale what the decision making was behind that.
Right, well, and as you correctly pointed out earlier, we were and still are, in terms of social care, working with imperfect data, so we wouldn't disagree with that at all. And that's a ongoing debate actually with local government and with the sector. Now, as Ross pointed out, the way stress testing works in basically a local government managed service as opposed to the NHS is fundamentally different. So what stress testing was done in terms of social care goes mainly to local authorities themselves, who have primary statutory duty, and then local resilience fora. And that's the system on that side of the house. Obviously, the NHS is very different, and as part of the arrangements that Simon and Amanda put in, a lot was done at the national level. So there are systems on both sides of the house, but they are very different systems. Roz, do you want to add?
Yeah, if I can add, I think that at a local level, emergency planning is done as a system. And I'm just looking back, we reminded local authorities in March that they should be, by drawing on their pre-existing plans for pandemic influenza, should take a number of measures, which includes testing their business continuity plans, taking stock of how to maintain viable care home provision, look at how they work with the NHS to support care providers, and have a plan for how and when that would be triggered. I think the thing that we didn't have at the 13th of March, when we issued that particular advice, was getting all of that back in. I think now we have got from every local authority across England have sent us their care support plans, and we can see, looking through that, how far back some of that goes, which is what we would expect. So we have stepped in much further than we would normally in relation to local government as this has gone on.
Mahendra. Mr. Mahendra, I just need to unmute Mr. Mahendra. If you stay unmuted while you're asking questions, please, that'd be easier. Thank you.
Apologies. Thank you, Chairman. My next question is to Catherine Francis. Obviously, we've just heard from colleagues at Department of Health and Social Care that the onus was on local government to check whether care homes had sufficient capacity and stress testing. Can I get your views on that?
Yes, of course. In terms of, and if I may come back on your question earlier about joined-up planning as well, alluding to the point that Chris Wormald made about LRFs. I mean, on local government's role, I think the key point is that local councils do have statutory responsibilities to manage their market, to ensure that they have a continuity of provision, and they play a really lead role in terms of the local infection teams working with Public Health England and others in getting out there amongst care homes normally. So I think what we've asked them to do in central government is essentially a sort of extenuation and a lean into that role, and we have worked with them and supported them quite heavily in doing that. So when they're looking at the moment about their local plans for social care, they're really bringing together all of the local parts of the jigsaw. So they're confirming, do the NHS play their role in care homes as expected? Is the funding flowing through? Are the infection plans in place? They're bringing it together, and I think that's what we've tried to resource them to do. Just looping back, if I may, on your point about joined-up planning, Chris Wormald alluded to local resilience fora, and I think it's just important to note that all parts of England do have these resilience fora in place. And as you probably know, they bring together NHS as well as local government and all the Category 1 responders. And we work for government with those LRFs in each place. They have all had plans in place, and we have had very close contact with them throughout this crisis to hear the key messages that they're feeding back to the centre and where they are requesting help. And it's helped form government's response and government's policy in areas like PPE.
Right. Can I, Mr. Mahendra, have you got anything else? Or just on the issue of PPE, I know we're going to touch on this a bit more later, but I've had, for instance, my local hospice was in the pipeline to receive PPE through NHS supply, and then the plug was just pulled on that suddenly. So care homes and hospices suddenly were unable to access it through that direct route. Why was that, Sir Chris?
I'll ask Ros to answer.
If it's Ros Roughton, I should be directing that to. I'll direct it to Ros Roughton then. But I do need to be clear when we. Okay, I'll talk about carry on through the bell, Ms. Roughton. We'll just manage.
So at no point has there been an instruction for the NHS to be prioritised over the care sector, and every time that's been raised with us, so I think I've had 3 or 4 things directed to me or to our ministers. We have looked into it, and it has not been that things were redirected to the NHS away from the care sector. What we've done on PPE has been providing some emergency lines to the care sector through the National Supply Disruption Centre and through LRS. But we've also, through our procurement, have then sold on to wholesalers that care providers could kind of access PPE, buy PPE as business as usual. So, but we issued any instruction to prioritise the NHS.
Ms. Roughton, one of the things here is that hospices were downgraded to the level of care facilities rather than hospitals, even though they have to because of the certain standards they have to reach. I think I'll write to you about this, because what you're telling me is not the experience of St Joseph's Hospice on the ground and other hospices around the country. So I think it's important that lessons are learned from this, but I think it would be helpful to take that offline. I'm going to bring in Nick Smith, and then I'm going to bring in Richard Holden, then go back to Gagan Mahindra. Nick Smith.
Thank you, Chair. And I've got a follow-up question to Sir Chris Wormald, please, sir. I want to return to this issue of discharge from NHS hospitals into care settings. On page 47, paragraph 3.19, it says that guidance from the 2nd of April stated that care homes could admit patients with COVID-19. Given what we knew at the time on what was happening in places like Italy in care homes, do you now accept that was a high risk and wrong guidance?
Well, again, I'll ask Ros to answer.
No, Mr. Warwell,
he wants Mr. Okay, Mr. Chris. Sir Chris.
Well, I will ask Ros to comment afterwards.
Actually, Sir Chris, it is a matter for the committee and the chair to decide, but you think she's got something to contribute. We hear that. Yeah. Sir Chris.
Sorry, Chair. As I've said before, we believe that we took the right decisions based on the right clinical evidence at the time. Now, why I'm thinking through my answer quite carefully here is for the reason that I said before, that we are both undefensive and reflective on what we have done, both in the NHS and in social care. So I'm not going to say that every single piece of our guidance was correct, and we are in a process of learning as we go along about these entire issues. So I'm confident that based on the information we had at the time, our guidance was correct. That is not the same as saying we would do the same again. But if the chair will allow, I'll ask Ros to add.
Well, Chair. So Nick Smith.
Could I just come back to, please, Sir Chris, to answer my question? Given that there were 400,000 vulnerable residents in care homes, do you think that the guidance that care homes could admit patients with COVID-19 was high risk? There were clearly risks in whatever you do in these
these circumstances. So I'm not going to deny there were risks. All our guidance is very carefully considered and based on the best clinical advice at the time, but that's not the same as there being no risk. Now, as Professor Harris set out earlier, there are considerable risks to people staying in hospital, both outside a COVID outbreak and within it. So when we are setting our guidance on all these issues, we are having to take balance of risk judgments where there is no risk option. So we acted on the clinical advice that we had at the time. As I said in my previous answer, that is not the same as saying that we always got things.
We've got that message that you say you didn't always get things right, Mr. Smith. We would accept that.
Chair. So, Chris, you said the advice came through from Public Health England.
No, sorry, I haven't said that, and I'm not in the business, and I want to be very clear about this. There is no sense here where we are seeking to push responsibility for decisions onto other organisations.
Okay, thank you, Mr. Smith.
Well, I'll just explain what happens with clinical advice. Our clinical advice comes from a range of clinical sources, two of which are at this committee today, but also includes the CMO and his team of deputy CMOs. They talk all the time, and the clinical advice that the government as a whole acts on is the best clinical advice available from a range of sources. As I say, we are not in the business of saying this organisation said that and therefore responsibility goes.
Okay, yes, thank you.
The government as a whole acts on the clinical advice that people like.
I think we did understand that. I think we need to sort of cut back on the explanation of how things work. We have prepared, we know the report, we cover this area quite a lot. Mr. Smith.
Yes, it was only because the issue was directly raised.
Right, okay, point taken, but we do need to have quick questions and quick answers, and Mr. Nick Smith is going to be an exemplar in that, I know. Mr. Smith.
Thank you, Chair. My next question is to Rosamund Broughton. It's about data on deaths in care homes. I found in South Wales it really difficult to get up-to-date information on deaths in care homes in particular settings. And certainly I know that in local government, locally, I've been told that if there was daily information on deaths in care homes, that would help with providing PPE and rushing towards improving the testing regime and providing care and support for care homes. Do you think the data on deaths in care home settings is sufficient to support the residents and the care home organisers?
I think it has improved since the start of this pandemic, and it's it's kind of awful information looking at it, and we look at it every day. So what we now got through CQC is collecting, we have data when they are notified of a death in a care home, and that information is published each week, broken down by local authorities. So that is now available.
Do you think you could do a better job if it was produced by care home by day?
I think that in order to manage the outbreak, it's important that local systems know where they need to be giving support, and clearly as soon as there is an outbreak in a care home, then that feels like the most important information. I suppose the question you're asking is whether that's kind of made public. Is that what you're asking?
It is really. I can understand why Public Health England and Wales would be afraid of scaring communities and unsettling residents, and that's the last thing anybody wants. But I've had local authorities tell me that information's been too slow on deaths in care homes, and maybe support for care homes could have been improved if there'd been increased transparency to allow local authorities and other services to help sooner rather than later.
Ros Roughton.
So I think that local, you know, as soon as there's been an outbreak in a care home, then local system leaders would have had that data straight away to help them manage the position. And I think the question for the public, you know, I think that transparency is always helpful generally. So I think that's a matter for care homes about the information that they're providing. But certainly I know that from the care home providers that I've spoken to is that when new people or the families that their existing residents, they take a very deep interest in what's going on and what measures they're taking to manage COVID in their care homes. And I think, you know, we are at a stage where we have got, you know, still a majority of care homes that haven't had an outbreak. And I do think that is testament to the fact that many care homes have got really well-established infection prevention and control procedures and have been supported in taking steps.
Can I just ask Professor Johnston, you talked earlier about PHE going in and advising care homes about this. Do you have enough staff on the ground to properly do that? Was that an issue?
We have 360 staff across 9 teams in our local.
Right, so is that enough?
Teams.
Because that seems quite like a very thinly spread to advise local authorities. Care homes.
It was certainly enough in the early stages when we had a lot of work on containment. But where we are in the pandemic now with the test and track part of the programme, we are ramping up the personnel in our local health protection teams to work with the joint biosecurity board.
So when you say ramping up, are you getting more staff in to do this?
We are, yes.
Where from?
We've had a good response from people who have retired. We need a range of people, from consultants, nurses and phone operators, and we're moving very quickly through to over 1,200 staff ready for the test and track.
If you could write just to tell us a bit more about where they've come from, that'd be helpful. Nick Smith, I think last one or two. Yeah, thank you. Thank you, very much, Mr. Smith. Very quick one from Richard Holden, MP. Richard Holden, and I'm going to move to Gagan Mahindra. So if you could unmute Mr. Mahindra.
Thank you, Chair. Ms. Morton, you mentioned that the majority of care homes in the country hadn't had incidents of COVID. That's not the case in County Durham, where I'm from, where the majority have had COVID cases. 2 very quick points. First of all, the Council has consistently said that their policy has been based on the guidance they've received from government. Yet they initially tied funding for coronavirus-related costs to homes being willing to accept those who tested positive for the virus or untested. Was it ever the government's guidance that more money should be given to those willing to accept patients from hospital who either had tested positive or were untested?
No.
Okay, that's good to know. And the second point I just wanted to raise was back in late March. So I've looked at your reports, the guidance you issued in March, and then the 2 sets of guidance in April. And now the BBC, under an investigation, were told that there was a conference call between a care home association in County Durham and council officials, in which they said that the council were told that releasing patients into care homes without testing would be disastrous, and the local association offered to find specific homes or homes where COVID-19 positive or untested patients could be cared for separate to the rest of the network. Having looked at the select committee report, sorry, Chair, that guidance on keeping separate only looks like from the national level to come through in April. Was that actually your guidance before to keep them separate, or was that guidance only later?
I think it was only later. I think something we had discussed with care home providers, but I think it was something that it's not possible in every care home to do that. So mandating it would kind of create a different sorts of risk. So it wasn't something that we really talked about isolation rather than doing kind of actually separate care homes at the outset. So that was a kind of later proposition, I think.
Sorry, but early on you did talk about, in your earlier guidance in March, you talked about isolating patients away from general communities. Okay.
Yes, dedicated isolation facilities.
Thank you very much. Thank you very much, Mr. Holden. I'm going to go back to Gagan Mahindra and then to Geoffrey Clifton-Brown. Gagan Mahindra.
Thank you very much, Chairman. I'm going to move on to talking about caring for people in the hospital. I think we'd all agree that the provision made by the likes of the Nightingales was excellent and ensured that the NHS did not fall over. But my question is to do with what lessons have we learned from that? Because we are, based on history, expecting a second wave. A lot of frontline staff would have been exhausted from doing first wave. We've got a backlog of non-COVID related operations required. What are the plans in place at the moment? Can I direct my question to Amanda Pritchard, please?
Amanda Pritchard. You unmute. Could you please unmute, Ms. Pritchard? Thank you. You're still muted. Thank you.
Hopefully that's just worked. Thank you. Thank you very much for that question, and particularly for your reflections on the Nightingales. I think the comments made on the experience of staff over the last few months are also really well made. So part of where we are at the moment is clearly trying to find, and it's in the letter that Simon and I wrote on the 29th of April, the right balance between giving clear instructions to the NHS that says we now need to operate very much in a with COVID environment. So the first priority clearly to keep patients and staff safe as we continue to have a certain amount of coronavirus with us and expect to do so for some considerable period of time. But clearly we also now want to make sure that people are supported to restart critical services. We have seen, obviously, emergency services and critical services such as cancer maintained throughout, but the opportunity now to increase some of the proactive offer of those services out to people who need them. And I guess the third component is then very much making sure that we have thought about very carefully what flexible capacity we need to have available to us as we head into autumn and winter to respond to what then might be further demands from coronavirus into winter. So we are hoping and planning at the moment to maintain, for example, the Nightingale facilities on a standby basis. So we don't need them now, but to be able to bring them back into operation within a very short time, a matter of literally a few days, is one of the things that would give us some of that security.
Thank you. Ms. Mahindra.
But yeah, so just building on that, obviously later in the year we would be expecting the seasonal winter pressures. How is that being planned for? Because the concern that I have and NHS providers have is that there is so much capacity in the system. If we have multiple demands on the system, it may fall over. So what planning are we doing now in the relative peacetime to ensure that we're ready for the battle ahead?
Amanda Pritchard.
Thank you. So, I mean, very active discussions underway at the moment with colleagues within DHSC and government more widely about exactly that issue. Part of the answer is, as I say, our hope that we'll be able to maintain certainly the Nightingale flexibility, and indeed we're in very active conversations at the moment about the potential to continue to have access to the independent sector to provide us with some of that additional headroom, which we think we will need for the rest of the year. A couple of other things that's probably worth mentioning. One is very much around staff. So clearly our ability to continue to support the workforce, make sure that the extraordinary response that we've had over the first few months of the pandemic, that we're now giving people a bit of breathing time, encouraging people to take leave so that they are refreshed going into the autumn and winter, but also continuing to encourage people who have returned to stay with us. And people who have volunteered to continue to offer their support. I think the final point is that one of the things we're also really trying to emphasise this year is the flu vaccination campaign. So anything that we can do to make sure that we're trying to keep the population of people who might be at risk safe through winter will clearly help us to be more resilient.
Absolutely. Mr Mahindra.
Thank you. Amanda, you referred to working across government. Could you talk about the coordination between government departments and how that's working? And as a supplementary, we can look back at hindsight with the first phase of COVID. What, in your view, went wrong?
Thank you. So I think structurally, right from the very start, we've had a very coordinated approach in how we've responded to the pandemic. So just as an example, our own internal, most sort of senior governance group has had representation from DHSC right from the very beginning, and vice versa. We've talked already about the sort of daily clinical meetings that have been taking place, as well as within England across the 4 nations. So lots of examples, I think, of how the planning has been and the execution has been done absolutely in strong partnership right from the start. I guess your point about learning, I mean, I hope what we would say is that we're learning continuously. So a lot of the things, as colleagues have said throughout this hearing, that we have been doing over recent weeks and months are, of course, based on the very immediate feedback loops that we've had in place as data has improved, as we've learned more about the virus, as we've been able to put additional measures in place to strengthen and support our response. And our intention will be absolutely to continue to do that.
Mr Mahindra.
Yes, so just going back to my other question about the pent-up demand for non-COVID related procedures. I think the figure for April year on year is down 74% on elective. That is quite significant, and that may entail further attendees at A&E and the like, so it's a stitch in time versus 9 stitches later. So what plans do you have in place to unlock the non-COVID related procedures to actually ensure that the system doesn't fall over? Amanda.
Yes, thank you. So as I said earlier, one of the things that we have been very careful about doing is maintaining the access for kind of critical services throughout. So in terms of a sort of safety first approach and a clinically led approach, that's been very much at the kind of heart of the NHS response. The letter that we wrote on, that Simon and I sent at the end of April, I think very much reinforced that, but also was a very, I guess, clear encouragement to now start to proactively stand up services and go as far as possible where people can, to start to very much get, exactly as you say, into some of those more kind of elective areas of service. It's where I think we would say the partnership with the independent sector can now be re-geared to originally very much focused, of course, on supporting us through that first phase response, potential now to see that geared around also helping us with some of the non-elective.
Okay, we're going to come to that. Mr Mahindra, thank you. Mr Mahindra.
So just thinking about the wider healthcare system, we've obviously focused a lot on hospitals and care homes, but things like dentists or osteopaths, which if certain conditions aren't treated early, they could quickly spiral out to trial like mouth cancer. What are we doing to ensure that people have some guidance that these other services are coming back online?
Thank you. So if that's back to me.
Sorry,
so we have now written out, for example, to dentistry, just very recently, been very clear what the restart arrangements are in place for dentistry. Again, of course, what we focused on over the first phase was the continuation of urgent dental care. But I think we're very much with you in thinking that.
So just on that, Amanda, I've got some personal history that in terms of family member. Wasn't it that only if effectively you needed a tooth pulled out and nothing else was going to be done? So it was very much a black or white decision. Either you get the tooth pulled out or we're not seeing you.
So I think that, again, we're back to being very much, as you would expect me to say, clinically led on what the kind of safety equation was around all of the clinical services that we've been seeking to maintain. And that's equally true of dentistry as it would be for anything else. So weighing up for individuals, and it's got to be, of course, a local clinical decision, and that's why the triage arrangements around dentistry were put in place to support the urgent dental centres. So we've done over 800,000 virtual triage appointments for dentistry, and for those where the local clinical judgment was that the balance of risk was such that it was preferable for somebody to come in for a face-to-face appointment rather than be managed remotely, then those that was the purpose behind setting up that network of urgent dental centres to try and guide people appropriately.
Thank you.
So just one statement before I pass on, Chairman. Amanda, you mentioned virtual triage. I think that's definitely the way forward. I know my own local acute hospital, Watford General, had a very successful 1,000-bed virtual hospital. So I look forward to seeing future plans.
Thank you very much, Mr Mahindra. I'm going to now turn to Sir Geoffrey Clifton-Brown. I'll just remind members of the time. Sir Geoffrey Clifton-Brown, if you could unmute, please, Sir Geoffrey. Thank you.
I am muted. I think I'd like to turn to Sir Chris in the first instance anyway, on PPE. Back to this level 4 incident declared on the 30th of January, what did PHE do to start ramping up their supplies on PPE after that incident was declared?
Well, it's not a particular PHE responsibility. So the business as usual position on PPE is institutions both within the health service and within the social care sector are responsible for procuring their own PPE. That's what happens in the normal course of events. Public Health England maintains the known as the PIP stockpile, which is the pandemic influenza stockpile that was begun in 2009. That's their specific responsibility. What we did essentially in this crisis, beginning really in late January and then ramping up, was increasingly make the provision of PPE a national responsibility, both within the NHS and the social care service. We put together, this is something that Simon and I did, we put together effectively a joint cell between our commercial operations in the department and the and the NHS, and they increasingly became responsible, working with the Foreign Office and others for sourcing international supplies of PPE and delivering it both to the health sector and to the social care.
So Geoffrey,
we managed it in way.
So Geoffrey, if I could just point you to your phone, thank you. So are you moving on now, Sir Geoffrey, to the next part? Thank you.
Right, you would like me to do private hospitals now?
Thank you. Yes, please.
Yes. Okay. So Simon, you went out to the private sector and procured a contract for 8,000 beds. This was procured on the 21st of March and runs till the 28th of June. Will it be renewed after that?
Thank you.
So Simon.
As Amanda Pritchard said a moment ago, we do expect that we will want to make use of independent sector capacity for the balance of the year in order to give more buffer for routine surgery, cancer care and other conditions. But the basis on which we are contracting with the independent sector is likely to change, in that in this first several months the purpose was essentially to have reserve capacity in the event that the forecasts that were given to us showing this huge increase in the number of inpatients came to pass. We would have needed to use those beds for that. Now, in this next phase, we want to use them specifically for elective care, diagnostics, cancer and so forth. So we're in discussion with government about that, but my hunch is that we will want to sustain a relationship with the independent hospitals.
So how much does it cost, this contract cost to date, and what discussions are you having on how much money will you need to do what you've just said for the next phase of the contract?
The contract to date has been on a at-cost basis with open book accounting and independent audit. Those figures are still in the process of being trued up, so I don't want to give an unaudited number today, but the basis on which we would expect to proceed here on in will be a different type of arrangement, probably following a competitive procurement.
And will this open book arrangement that you've negotiated hitherto be fully open and transparent? Because we're hearing stories of high interest rates on loans being charged, of bonuses to directors and others being charged. So will the basis of it be totally transparent?
Yes, with independent audit, and indeed the contract explicitly prohibits compensation for bonus payments or executive pay beyond that which would have been accepted through the NHS, and indeed contains caps on the profits that can be dividends and other aspects of what would be a normal cost structure for those providers.
And final question, given Mr. Mahindra's questions on getting back to NHS as normal on elective surgery, how will these hospitals be allocated to each health trust to carry out their elective surgery if the phase 2 contract is negotiated?
Well, I don't want to preempt the discussions that we're having with the independent hospitals and indeed with government, but what we will be doing is essentially making that capacity available to networks of hospitals and GPs in an area, and then the exact mechanism by which patients come to choose to have their operation there, we will negotiate over the coming weeks.
Thank you.
Thank you very much.
Thank you very much. Because Simon, while we're just on this subject, can you tell us how many of the 8,000 beds in the private hospitals that you commissioned have been used at any time to date? What the capacity's been?
Well, remember, the reason we booked these beds was not solely to use them for hospital admissions. We actually redeployed a number of
but that's not my question. Is how many of them have been used for anything? I mean, just used at all by the you paid for them. So how many of them have been used? We paid for them.
Several 100,000 patient treatments. In
sorry, I didn't hear that. Several 100,000 or 700,000?
Several 100,000 patient treatments, but that's a combination of operations, outpatient spells, chemotherapy treatments, diagnostic tests, and in addition, we redeployed, we pulled staff out of those hospitals and used them where they were needed across the NHS, and we also deployed equipment from the where they were needed as well. So this was not principally an activity-based contract. This was a capacity.
No, no one disputes that. I'm just wondering how many of the 8,000. I mean, so some of them would have been day cases, some of them would have been people residentially for operations. Yeah. It'd be very helpful if you could supply us with some of that data, because I think it's really useful to know when that resource was pulled in, how much of it was used. That's all I'm asking. So you're saying me several 100,000 patient experiences.
Yeah.
But you can't give any more detail than that? Or can you write to us with it, please?
Well, as I say, it's a combination of diagnostic tests, chemotherapy, outpatient attendance, day cases, so varies between sites. That's not the principal metric on which to judge the use of this capacity hitherto. It's been the use of the staffing that was there as well as the equipment.
But I think it's useful to know for what taxpayers spent on that, what we got back. That's all. Sure. That's all I'm asking. So you could write to us with that information.
Yeah, absolutely.
Thank you very much.
We got back more than that count of patient treatments.
That's fine. Thank you very much. And when you talk about the costs that you're negotiating, or hasn't been audited yet, can you give us a figure in a ballpark figure? What's it in the region of?
I'd rather wait until we have those audited data, and then I'll be happy to write to you with that.
Okay. Well, when will you expect to get that audited data?
Well, as Sir Geoffrey said, the first round of the contract expires June 28th, but there will be a short extension while the re-procurement selectively is occurring. So certainly within the next several weeks, I would imagine.
Okay, I'm sure our colleagues at the National Audit Office will be keen to have a look at that as well. Okay, I'm going to move on.
Chair, can I just,
sorry, Sir Geoffrey.
Can I just ask one final question to Sir Simon, please? Simon, it's my impression that some of these private hospitals haven't been used all that much. Is the basis of this open book arrangement on this first phase of the contract such that if the hospital isn't used, it isn't paid, or would it expect to get a certain amount of its overheads under the contract, irrespective of whether it's used or not?
During the block booking phase, we would essentially be compensating at cost with an offset for any private patients that they took through those facilities, so that that then offsets our costs. But for this next phase, we are likely to prune the list of facilities based on expected usage for the balance of the year.
Okay, so you've learned from what's happened. That's good. Well, we look forward to the figures. I'm going to pass now back to. Thank you very much, Sir Geoffrey. I'm going to pass now back to Gagan Mahindra, and if I can just alert Nick Smith that to be ready. Gagan Mahindra.
Thank you, Chairman. My question is going to be about PPE, or my list of questions about PPE. This is notwithstanding a future report that the NAO, I'm sure, will be doing. My question is to Professor Paul Johnston. If you look at the NEO report on page 58, section 4.19 downwards, it refers to the new and emerging respiratory virus threats advisory group, and it says gave warning this time last year that certain stockpiles of PPE were not sufficient. Can you just run us through what's happened and why we didn't have sufficient PPE when we needed it because of COVID?
Okay, thank you for your question. I think I'd like to just start with where the Permanent Secretary, what he said on this, which is what is PHE's responsibility for PPE. So we have two very clear areas of responsibility. One is simply to hold the stock on behalf of the DHSC, and the second is to receive, where there are advice from NERVTAG, to receive commissions from the DHSC to go to a procurement, go through a procurement exercise to change or adjust stock.
Thank you for that. So, therefore, the actual policy decisions would have been via either Sir Chris or Sir Simon. So the same question to you both then. This time last year, there was an independent report suggesting that we needed increase in PPE. What was done between now and, say, beginning of this year to fill that gap?
Yeah, I'll take this. I mean, it is exactly as set out on page 58 of the National Audit Office report. So there was an outline NERVTAG recommendation in June 2019 to add gowns to the stockpile. We then received the technical specifications from a further NERVTAG report in November 2019, and a procurement was planned for early 2020. Now that was, of course, overtaken by events, and we went over to buying for immediate delivery rather than buying for a future stockpile. But the story is exactly as set out by the National Audit Office.
Mahindra.
Sir Simon.
Sir Simon Stevens.
Yep, no, I think Chris has just explained the situation. The NERVTAG, as I understand it, made the recommendation, and the department were in the process of responding at the point that coronavirus then hit, as Chris has just said.
So, Sir Chris, obviously, I think you were still the Permanent Secretary 4 years ago when we had exercise sickness, which was to do with the pandemic, and that did specify that we did not have sufficient PPE. What was done since those 4 years? Because obviously there seems to have been a history of red flags that this may have been an issue. Now, obviously we've benefited from hindsight here, but I'm just trying to get the rationale why this wasn't addressed 4 years ago or in the intervening period.
Well, the buffer population sickness was addressed, including what it said about PPE. But now we didn't cover the issue we've just been discussing. That, as set out in the NAO report, was a considerably later recommendation. So basically, what happened with Operation Readyness, I mean, this was something that was done with the department and by the department. There were a series of recommendations from us to put in a better place, which were implemented. And a number of those have played out in how we have responded to the coronavirus crisis. The thing I would say, of course, was this was a test of a pandemic flu pandemic, which has a series of clinical differences from the pandemic we are currently facing, including, and some of my medical colleagues will be better placed to comment, but I'll give you the sort of summary version. A coronavirus turns out to place considerably more stress upon PPE due to the hospitalisation rate and need for PPE in other circumstances than we had projected from pandemic influenza. So the stockpile we've built up that was, say, begun after the swine flu issues has been completely invaluable in dealing with coronavirus. We've used it intensely, as the NAO report sets out, but it wasn't specifically designed for this type of pandemic.
Mr. Mahindra.
I appreciate that it wasn't exactly the right type of pandemic, but I would hope...
I'm not being defensive about this. I'm simply stating the fact as to what the stockpile was for. But on your basic question, yes, we followed up all the recommendations for Operation Sickness.
So we are still anticipating a second wave until we find a cure for the COVID-19. Where are we in planning to make sure that we have sufficient PPE to match that? I've alluded to the fact we are currently seeing the back end of the first wave. Now is the time to ramp up manufacturing or supply. Do we have that in place? What reassurance can you give this committee that we're on top of this?
You are exactly right. It's obviously not certain there will be a second wave, and we certainly hope there will not be, but our planning needs to be on the basis of reasonable worst case scenarios. Now, as I described to the committee last time I was here, the PPE position, for a variety of reasons, mainly to do with international supply, was extremely tight indeed. We are pleased that we are now in a considerably better place, and to give you the sort of sense of where we have moved from. At the height of our challenges, our planning window was up to 7 days. That was
which we know from we do know that from the previous hearing. So you want to cut to what you've learned from that. What you're doing now.
We are now at a position where we're looking 90 days ahead and have plans for that, and we are putting in place plans right now to go beyond that. So I'm not saying that we have everything in place that we want to cover.
Can I just say you've got a 90-day plan? Could you just explain precisely what you're doing to make sure that you've got PPE 90 days out? Because one of the things we've discovered from the previous sessions we've had and from the front line is that you had supply coming in but not enough understanding of the demand in the very different sectors that needed PPE, and yet...
that's exactly right. Now,
so what are you doing to plug that gap?
As I think our questioners pointed out, the NAO is doing a full study of this, so I expect we will debate it in considerably more detail.
But we still tell us now.
In its summary version, we are doing 2 things over the next, to put us in a position where we have sort of line of sight for 90 days supply and then going further. One is certainty of overseas supply and longer term contracts that we are signing with suppliers. And the second is to expand, as we discussed previously, what we make domestically, which, while a small proportion at the moment of what we can supply, we want to be increasingly important going forward. Those are basically the two ways we can get PPE. So our plans that Lord Dighton is leading are looking at both. And then the third aspect is to better and better understand demand and ensure that our internal logistics, when I won't repeat what I said in the previous hearing about the challenges there, match that. And you put those 3 things together: understanding of demand, longer term contracts for international supply, and increasing domestic provision is what is putting us in a better place. But as I say, and Lord Dighton would, I'm sure, say this if he was here, we have more to do to move on from a sort of 90-day plan.
Thank you.
To longer.
Okay, Mr. Mahindra, last couple of points.
So Simon, could you answer the same question? Because from my understanding, if we're looking to get all non-COVID related operations back up and running, we're going to need double the PPE that we're currently using. What plans have you got in place to make sure that's in place before we open up the floodgates?
We have, as the NHS, provided the central PPE team, the department under Lord Dighton, with the expected demand volumes that would be required, as you just pointed out to Mr. Mahindra, and so they then are seeking to source that volume at 90 days and beyond in the way that Chris Wormall's just said.
Thank you. Gagan Mahindra?
I think that's it for me at the moment.
Thank you very much indeed. I'm going to just bring in Peter Grant and then Nick Smith. So Peter Grant, MP, please, if you can unmute, and then if Nick Smith could also unmute now in preparation. Thank you. Mr. Grant.
Thank you, Chair. Could I ask Ros Broughton, at what point did it become clear that there was going to be a serious issue with the supply of personal protective equipment in the care home sector in particular?
So I think when we first got the advice about use of face masks, and that was something that was new on the whole for the care sector. So I think gloves and aprons are things that care providers have always used. And as you'll know, care providers, in normal times, they have a multitude of wholesalers or retailers that they get their supplies from. So we did issue an initial kind of drop to get people over that very first hump when we issued the guidance on face masks. And I think that first sort of couple of weeks, it was very, very tight, and it was very difficult.
Could you tell us what dates you're talking about there, please?
Sorry, so I think that on the 13th of March, when we issued the guidance about use of face masks, and we issued, and that's when we made the initial drop from the pandemic flu stock of PPE, of face masks to go alongside that. And I think then on the 2nd of April, when we changed the advice around, so this is about using PPE for care home residents who weren't necessarily symptomatic, so kind of widespread use, and that was something which very much increased the demand, I think, beyond what we had originally anticipated.
So why was there such an under-anticipation of the need for protective equipment in care homes where we knew there was around 400,000 vulnerable people living? Why did nobody spot that danger until it came and hit us?
I think it wasn't to do with the care homes, but to do with the nature of the transmission. So the amount of PPE used for this particular virus, that the advice, which is kind of has changed during the course of this, as kind of people have got to understand it better. That was something that we hadn't anticipated.
Does that mean you hadn't anticipated the nature of transmission?
Sorry, Mr. Grant. Yes, Mr. Grant, ask your question. Sorry.
Yeah. Does that mean that you hadn't anticipated a virus that could be spread so easily by particular methods, or had you just underestimated generally the R number of this virus?
Well, I think I'd ask Professor Johnston to comment on the kind of planning around what kinds of virus and the transmission rates, methods of transmission.
Chairman, shall I come in here?
Please, Professor Johnston.
Thank you. So this virus, the nature of this virus was not clear to the whole of the world when it started. It's a new virus. And what was becoming clear in the back end of March, and certainly from the beginning of April, was that there was a asymptomatic phase, which means that people can transfer it without ever having symptoms, or a significant pre-symptomatic phase, which is where the virus could be shared and then someone would
yeah, we know. Yeah, we understand the
symptoms.
terms. Yeah, thank you.
Yeah, and this was learning throughout the pandemic globally, and therefore the advice on PPE that was changing reflected the most up-to-date advice that we learned from WHO and others.
Mr. Grant, we need to move along fairly quickly. So, Mr. Grant.
Thank you. The NEO report points out that the stockpiles didn't significantly increase during January and February. By that time, weren't we picking up information that at least warned us that this virus wasn't going to behave the way we expected it to if we did the previous exercise?
Shall I say that? That's because we were already beginning to give out material from the stockpile from late January. So the three actions that we took before the clinical position was absolutely clear. Two at the end of January. We began international purchasing towards the end of January. And we began to release from the pit stockpile towards the end of January, and then we stood up the National Supply Disruption Response hotline from mid-March. So we were already taking action to deliver PPE in the into the health and care sectors before we were clear on the clinical need that Professor Johnson has just changed. So I may have to check just the date of one of those answers.
Okay, well, you can tell us the date. Come back on the date. You can write to us, or we can pick it up at the end. So, Mr. Grant, is that you nearly done?
Thank you. Thank you.
So Geoffrey Clifton-Brown's got a couple of quick ones on this point, and then I'm going to Nick Smith next. So Geoffrey, a couple of quick points, please. Thank you.
Two questions for Chris, please. You had 2.5 months from the first coronavirus case to the appointment of Lord Dayton on the 19th of April. How was it that you were running into significant shortages of PPE up to the time he was appointed? In about 6 weeks, he was able to boost your supplies from about 1 billion to about 5 billion items. Why couldn't the NHS, and particularly PHE, have managed that much quicker?
Who's that? Geoffrey. Chris.
Now I'll correct my previous answer. Now I've got the opportunity. It was in February that we began international buying. Now the story of PPE is one of continuous advancement. So we were boosting international supply throughout that period. Lord Dayton has done a brilliant job and has boosted it yet further. But in the way I've just described, we were very active on PPE right from the outset. As I described in the previous hearing, our challenges have been twofold. The biggest has been basically the world demand outstripped world supply. And we have seen countries all over the world, including some of those who are said to have managed the virus extremely well, including
we don't need to listen.
Reporting similar challenges with PPE.
But Sir Chris, if anything, the situation had got tougher when Lord Dayton was appointed, because the whole world was wanting PPE, and yet he still managed to increase this quantity very significantly.
Oh yeah, well, and I'm not going to underplay what Lord Dayton has achieved at all. Now, at the same time, however, as you would expect, world supply increased as demand increased, and we have seen less challenges in sourcing international supply as time has gone on, as world markets have adapted. That is not to downplay at all what Lord Dayton has brought, which, as you say, has been excellent.
So, final question, Chris, because time is moving on. I have taken part every single week in conference calls with our health chiefs in Gloucestershire, and I'm sure that Gloucestershire are not unique in what I'm about to say, and it's this. The guidelines on the use of PPE were constantly changed. It seemed to the health chiefs and myself change without regard to what the supply situation was in the country. and therefore exacerbating the whole shortage of PPE. Supply didn't match the guidelines. Was that the question?
Now, the way we set the guidelines does have to be the interaction of two things. One is what is clinically appropriate, clearly, and as Professor Johnson was describing earlier, that has changed over the course of the virus as our understanding has changed, and clearly our guidance has to keep track of that. And the second bit is supply. So it is not entirely driven by what is available and shouldn't be. What we try and do as we update our guidance is put out guidance that is both clinically appropriate and that we can then supply, and that is a balance of those two factors, and that's how the guidance is set. I'm not going to deny the guidance has changed, and we did it quite deliberately as both our supply changed and our understanding the clinical nature of the disease changed.
Well, I think we would...
Chair, I must come back on Sir Chris. One final question on that. What on earth was the point in changing the guidelines? At one point, the guidelines said that every single new patient that an assistant in a care home visited had to have new PPE each time they visited a different patient. This caused considerable anxiety in the social care sector. Surely there was no point in changing the guidelines, even if the clinical need altered, until you were sure you had sufficient supply.
Well, the changes we made were away from that provision for the reason that you say, and that's what we try and do as we update our guidance. We are trying to match clinical need with what we can supply. And of course,
but Sir Chris, you can't get away with saying the guidelines were away from that provision when you put that guideline in place in the first place.
Well, I mean that was the original advice about what should be done, and as I say, we can't be simply driven by supply in this case, because the two interact. You know, what we ask our commercial teams to go out and buy is based upon our assessment of what is clinically needed at the time. It's not
I think Sir Geoffrey raised an important point, which the NEO will no doubt be looking into when they look at the procurement, about which was first, guidance or supply. But we'll come back to that, I think, in a future hearing, because it's a knotty point. I'm going to bring in Nick Smith and then Olivia Blake. Nick Smith. Thank you, Sir Geoffrey.
Thank you, Chair. A question to Sir Chris, please. Parts of the care sector are under huge business pressures. Do you expect to have to rescue failing care home providers in the weeks ahead?
Well, I refer you to the answer that Ros Broughton gave earlier. We have a regime for assessing the viability of care homes, which is partly national in relation to the biggest care providers, but mainly a statutory duty, certainly within England, I couldn't comment on Wales, of local authorities. Now, the point of our regime is to ensure the continued provision of services to individuals. That is not the same as rescuing individual providers. That may be the appropriate course of action, or it may not. The decisions are taken based on securing the provision of supply for individuals, and that's quite frequently examples where we've seen these recently, where one provider takes over the provision of a provider which has gone out of business. As I say, our decision making is based on what maintains the provision of supply, not what is good or not.
Thank you. Nick Smith.
Thank you, Chair. So, Chris, given that the sector is foundering at the moment, the sector is saying that costs are up and income is down, do you expect to have to rescue any of these groups that are large national providers over the coming weeks?
Well, I'm not going to comment on individual cases. I've explained the failure regime that we have in place, and we are also as Ross has also described already, in constant dialogue with the sector about questions of viability and funding. I'm not going to speculate about what we might do in the future.
Mr. Smith.
Thank you, Chair.
Olivia Blake.
Okay, I've got some quick questions for Amanda Pritchard. What proportion of the increase of the 18,200 in staffing was from student and pre-reg nurses? Do you hold that data?
Amanda Pritchard, can you unmute?
Yeah,
thank you.
Thank you very much. So we had so the figures that we have are a little bit more up to date than the figures in the audit office report. So what we do know is that from students, we had originally about 30,000 nursing, midwifery, AHP students come forward and offer to move into formalised placements, of whom 20,000 roughly have been working in practice. So about 25,000 were able to be deployed, and about 20,000 in practice have taken up those placements.
Right. Can I ask, has the NMC temporary registration for students and pre-registered nurses ever opened? Because I think the original letter mentioned it, but I'd just like an update on that.
Ms. Pritchard.
Thank you. Thank you. Actually, I'm not. I don't want to give you the wrong answer on that one. What I can say is certainly what we've tried to do with support from the NMC and others is make sure that we're not putting students in a position where they're unsupported. So what they've done is moved into positions where, rather than being supernumerary, they are still supervised. So that's quite an important distinction in terms of making sure that people weren't working outside their sort of comfortable scope of practice. But in terms of the temporary registration, I'll have to come back to confirm that.
Why has it's obviously been in the news that the programme for student nurses has been cut short. What reason is there for that?
Thank you. So I think there was clearly, regrettably, some confusion over the actual nature of the arrangements that were put in place. And I think it's probably just worth saying that actually, of course, this has been an enormously important contribution that all of those students have made in supporting the NHS, and it's been invaluable in giving that sort of that resilience that we talked about earlier. The intention was always that for third-year students, once they have completed their training, they would then, of course, be able to move into substantive positions, because they would reach a point where they were then qualified. So at the moment, those people have been working in effectively band 4 positions, and once they're qualified, obviously they can then move into band 5 positions. So the intention at the moment is that for that group of students, it wouldn't be that there would be a premature end. It would be more that they were then moving into substantive placements at a more senior grade. Slightly more complicated, of course, for second year students, because the intention there is that at the point where they have completed the hours required in clinical practice, we do then provide the right support to move back into the academic part of their courses, because it's obviously right that they continue their education, so that ultimately we're not depriving people of that opportunity when they have put themselves forward to take on this particularly important role.
Thank you. Ms. Blake, Olivia Blake.
I was just wondering if you think can envisage any operational impact if there's a second wave or a loss to the workforce, and also if there's any plans for more financial support for student nurses, and if you're concerned about some student nurses quitting as a result of the change.
Thank you. I mean, we'd be enormously disappointed if people felt undervalued as a consequence of the way that this has been played out. And one of the things that I know my colleagues in HEE and within NHSEI are committed to doing is to sending out some further clarification and further guidance imminently to try and give people a bit of support and greater clarity on the arrangements for them. And I know part of what they will be saying is how very grateful we all are for what people have done. Clearly, in terms of getting that right balance between education and service, that's something that they'll be thinking hard about as we go into the autumn, because the aim has been through this, as I said a moment ago, to find the right balance between supporting people to take on additional clinical practice, but not outside of an appropriate scope. And as we go into winter, clearly one of the things we're keen to do is to make sure people are not deprived of that educational experience.
Okay, thank you, Ms. Blake.
Just moving on to testing again, if that's okay. I'm particularly interested in Sheffield. Sheffield started testing their staff in the NHS Trust much earlier than using local provision. Why wasn't this encouraged in other areas? And why was testing for care homes capped?
That was about availability. We covered the capping a bit, but maybe could I bring in Ros Roughton?
Yeah, Ros.
Just briefly on that.
On the care home testing, we've made as many tests available as the testing capacity is ramped up. So I think we're now at about 70,000 a day for care homes. So it's simply a matter of prioritising across the whole of the country about testing. So,
Ms. Blake.
Okay, and why weren't other NHS trusts encouraged to do what Sheffield did? I think this needs to be answered by an NHS colleague.
Okay. Shall I come in on that?
Thank you, Professor Powis.
So we have been increasing testing of NHS staff. So clearly in the NHS, the priority has always been, as you heard earlier, to test patients, to test the patients who were coming in with symptoms and were sick because of COVID, and that stayed the same. We've also started testing all patients who are coming in as emergencies, as we've learned more about asymptomatic transmission in individuals. And we've also started testing staff who are asymptomatic, particularly where we see hospitals who are managing a lot of infection in hospitals. And we continue to evolve that. Different trusts have been asked to review that locally, and where they see a need for more testing, particularly if staff who don't have symptoms, then they will do that. And as, of course, the science evolves, we will continue to guide trusts. Final thing I'd say is that Public Health England have set up a large study called Siren, which is asking NHS staff to join that study, which will sequentially test staff with the antigen test. That's the test that determines whether you've got it, and an antibody test, the test that tells you whether you've had it. And it's that sort of academic endeavour that will actually give us the answers to a lot of the questions that we have been struggling with that are still unknown, such as the role of asymptomatic testing, and also whether immunity develops and how long it develops for. So much in the way that the NHS has led the world on dexamethasone and learning how to treat, doing these sorts of large-scale academic studies in the NHS will give us more information on how and when best to test.
Okay, just two more questions.
Very quickly.
This is to Prof. Paul Johnston and Ros again, if that's okay. Why have there been no excess deaths in hospices compared to the 20,000 plus in care homes? And does this show any difference in the way staff have been treated? And this is according to the PHE report on disparities that was released by Public Health England.
So who was that to, Ms. Blake? The bell going on here.
Professor Paul Johnston. And,
Professor Johnston first.
Thank you, Chair. So it's just quite early to make great pronouncements about death numbers, but care homes have clearly been a higher risk, and that reflects the higher numbers. I'm not sure if Ross wants to make another comment.
I don't know the reason for it, but it's something we definitely want to look at to learn from.
Okay, thank you very much.
Okay, I was just going to finally ask, what is the current availability of testing for these symptoms?
Sorry, could you repeat the question? It's difficult with the bell, I think.
Sorry,
no, it's gone.
How available is the testing now?
Who's that to?
For staff, for care staff.
Yeah.
So we are, as we've basically been doing a kind of sweep of offering blanket testing to all care home staff and all residents. And we've just been taking advice, and we'll be making decisions shortly about what policy will be going forward around repeat testing, what the frequency would be and where the priority should be in the care sector. So we'll have more to say later.
Thank you. I'm sure we'll have more to ask later too. I'm going to bring in James Wild MP and then Bernard Jenkins. So Bernard Jenkins, James Wild.
Thank you, Chair. I know from talking to nurses and doctors at the Queen Elizabeth Hospital in King's Lynn how affected they've been from dealing with the emotional trauma of treating patients with COVID and being with them in their final moments. So I want to ask a bit about mental health. And Simon, how is the NHS looking after the mental health of its employees?
So Simon Stevens.
Thank you, and you're quite right about that. This has obviously been a period without parallel in the professional and personal lives of everybody working in the health service, particularly those people who have looked after more than 101,000 mainly older people who've had emergency hospitalisation for coronavirus. And so part of the response has got to be ensuring that there is targeted psychological and mental health support available for staff across the health service. Last year, we for the first time introduced a dedicated practitioner health programme, a mental health programme for doctors, but we're asking those supports to be extended more widely by trusts and into primary care. And then for particular staff groups where their experience may have been different as well, for example, nurses from a Filipino background, we have been nationally putting in place particular helplines and support for them as well. But look, nobody has been unaffected, untouched by this. That's true in our personal lives as well as our professional lives, and you're quite right to point that out.
And how are you tracking that picture across the NHS, and what kind of picture do you have at the moment, and what's your forecast in terms of cases of PTSD that you think a proportion of the workforce might come forward with?
Well, in fact, I was talking about that very topic on Friday with Professor Sir Simon Wesley, who's the Regius Professor of Psychiatry down at the Institute of Psychiatry in King's College, London. And I think it's fair to say that on the one hand, there is an expectation that there will be increased anxiety and mental distress as a result. But PTSD in particular has obviously a very diagnostically precise term, and the advice from some other sort of equivalent areas is that actually it might not be PTSD specifically that we need to respond to. So part of what people like Professor Wesley and others are doing are actually tracking mental distress as distinct from mental disorder on the part of staff across the NHS, so that we can better design a mental health support offering that my colleague Claire Murdoch is working on doing.
Thank you.
Right, okay. I mean, even before the crisis hit, obviously mental health absence was an issue. You paused the people plan back in March. Do you have a date for when that's going to be published?
Well, in a sense, we've been getting on with a number of the building blocks or the elements of the people plan regardless, and one of the consequences actually of coronavirus over the last 3 months is that a lot of the things that we were planning on doing in the health service we have fast-tracked in a very flexible and agile way. The people plan itself is not just about the support for our current staff, it's also about the funding that we discussed last time, I think, for education and training expansions that Health Education England will be bringing about. And that's obviously a discussion we're having with the Department of Health and with government. But those aspects of the people plan that we can get on with as the NHS, we are getting on with.
That's good to know, because the interim plan didn't actually refer particularly to mental health. It talked about shortages of mental health services, nurses and other professions, but there wasn't a particular focus on treating mental health. If I could just turn to the wider population, obviously shielding, like other MPs, I get a lot of emails from constituents who are struggling, loneliness and other challenges. What's your assessment of problems that we're going to see in the wider society from mental health issues? Do you think this is just a temporary thing, and once the lockdown lifts, that people will be healthy again?
Well, again, the gold standard for mental health research in this area is actually doing interviews rather than online surveys. A lot of the reports to date have been quite small sample online surveys, so I don't think there's a good empirical fix to answer the size and shape of the problem, but we do believe there will be extra pressure on mental health services, and as a result we're going to need to fast track some of the service expansions that were already in hand as part of the long-term plan.
Okay, thank you, Chair.
Thank you. I think we've got lots to focus on there in future about where you're going to get all those people from for a start. Can I just ask, Sir Simon, you were given, allocated anyway from the Treasury, £6.6 billion as part of the funding you need to tackle this in an emergency. Can you just break down how that's been spent so far? What it's been spent on?
Well, I think it was laid out in the NAO report that we discussed last time, wasn't it? That was the detail. Well,
that was then. Have you got any update? Well, okay, let me drive at the point. Some of the money has been spent to support the peak, but because of the time it took to spend it, the peak has passed. So you've got people in temporary roles reallocated, retrained, etc. How much of that is money that's well spent that will have a dividend in the future, and how much of it is what I think the Treasury would tend to call dead money, dead weight money, because it's not actually delivering anything that you need right now? We expect in a sort of crisis that the planning won't always quite align, but have you done any analysis of that so that you can plan for any future peak?
Well, that is the discussion we are having with government as we speak, for the reasons that related to the question that was asked earlier about planning for a possible second peak and dealing with the overhang of services that had to be deferred during this first peak. I mean, I think it's worth just saying, Chair, that people are now taking it for granted that the NHS wasn't overwhelmed during this first period, but in fact that was anything but certain. All the evidence pointed to the fact that there would be potentially millions of people requiring hospital care. We saw in Wuhan, northern Italy, and so on. So actually,
we'd agree with you on that.
Reentry capacity was entirely appropriate, and indeed we've looked after.
My point, Sir Simon, is Sir Simon, I get that you can sometimes plan, and as I say, they don't always line up. You recruit people, you can't get them in time. Now you've got people in position, or you've got them out of retirement, or you've got them retrained, or you've got temporary staff in. You've got a cadre of people they're potentially able to help, but some on short-term contracts, etc. How are you going to make sure that the money that you've invested in that solution that didn't all get used is ready, waiting on the stocks if we hit a second peak?
Well, that's what we want to do, and that's the dialogue we're having with colleagues about what the right level of resourcing for that looks like for the balance of the year. I mean, one of the things that will be very important is ensuring that we in the NHS get a clear early signal from the new monitoring apparatus, the surveillance system, the joint biosecurity centre that is being created, that gives us at least several weeks advance notice of whether there is an emerging spike in a particular geography. Sorry, can you still hear me, by the way?
Yes, we can still hear you. Can I just say, ask then about, you had Nightingale hospitals, you had the private sector hospitals, and you suggested they used a lot of those staff. Did you have enough staff to deliver the care that you were buying in, whether it be in those two places or elsewhere? And do you have enough staff ready and available for any potential second peak to actually do this work?
Well, we went into the coronavirus emergency with a gross 100,000 staff vacancies across the NHS, as you know. Some of those were being covered by people working extra shifts, by temporary staff. As it happens, we have seen this fantastic response on the part of both those who have come back to the NHS as well as those who started their career early. And so, yes, under highly stressful circumstances, the NHS was able to cope. But, I won't deny the fact it was pretty scary at times. I mean, look, on the mid-March, 17th of March, we had a few hundred coronavirus patients. A week later, that was 3,500. A week after that, it was 11,000 in hospital beds. A week after that, it was 18,000. So, it's easy to just forget precisely how sharp was the increase in demand on staff and on capacity from mid-March through to the peak in mid-April.
And I partly asked the question because I think we have acknowledged that the NHS coped in a sense in that people bust a gut, work long hours, put in the time, but as Mr. Wilde has highlighted, at a great personal cost. And the question is whether they could do that again without being at such a personal cost that it's not possible. Perhaps I could bring in Amanda Pritchard on that, and then I'm going to ask Peter Grant very quickly to come in on something, and then last word to Sir Bernard Jenkins. So, Amanda Pritchard. Thank you.
Thank you. Thank you. And I think that does build on what Simon was saying earlier about the number of different initiatives that we've tried to put in place to support staff health and well-being, obviously focusing very much at the moment on making sure that primary responsibility that all health service leaders carry, no matter where they are in the system, which is to safety of their staff and the safety of their patients.
Well, that's the theory, and I'm not knocking it, Amanda Pritchard. That's the theory. The practical thing is now they've gone through this hell on earth. If you're in a critical care ward, if you haven't, you've been redeployed quite often elsewhere. You've worked like crazy to support our country. You're on your knees. You've got a gap where you're going to go back and treat all the patients who are in the backlog, and then you could have a second peak. So the theory's there, but actually in practical reality, what precise things are you doing to make sure that you're ready to cope with personnel-wise with the next peak, if it happens?
Yeah, thank you. So, I mean, clearly, there's a number of different strands to this. I think the first thing is to say this is kind of top of mind, because clearly part of it is having physical capacity useless if you don't then have the workforce and to make that able to be used to look after patients. So I do think it's a couple of things. I do think it is absolutely about the health and well-being point that colleagues have made, and that remains absolutely, as it was a critical theme through the People Plan, has remained something that has been a primary focus for us throughout nationally, regionally and locally. And every time, certainly I'm talking to colleagues in the health service, and I talk to them all the time, this is probably the first thing they will talk about, is how they can make sure that they're supporting their own staff, their own colleagues. The second thing is, again, it is also a very practical one. So so the thinking we're doing, of course, is about for those people who have so generously offered to return to the NHS. Let's try and make it possible for them to stay. Let's think really creatively about different models.
Okay, well that's very great. So you can want them to stay, but you won't have them. But you won't have the money. We've looked often at this committee about the money available to trusts. There isn't enough at settlement day to actually pay for why those vacancies weren't there just by accident. They're often there because there's not enough money to pay for them. So this money that you were given for the emergency, you still haven't got the guarantee you're going to get the next wave. Can you afford to staff the NHS at a higher level than you have been doing in order to cope with not just next peak, but generally with the pressures that this coronavirus has thrown up?
Yes, so that's obviously one of the things we're actively discussing with colleagues in DHSC and government at the moment. But many of those vacancies that were previous to COVID, which is still there now, of course, are to do with the supply of staff, not to do with a lack of resource. So it's both and I think that's why what we're trying to do at the moment is make sure that we're, as I say, doing the things that are within our control, which is very much about supporting the people who we've already got working with us and continuing to look at those more creative, radical ways that we have encouraged people to come back, to stay with us, and to think about also more flexible ways of using the workforce. So one of the things that we're clearly being asked to do by colleagues across the NHS is continue to build on that multidisciplinary working, that more flexible deployment model, which for many people has been a really energising thing to do. So those are the sorts of things that I think we're very clear we need to do to make sure that we're supporting the NHS to be ready for winter, whether there's a second wave or not, while we continue, of course, to work.
Okay, I think I would just contend that there's going to be an issue if you can't afford to pay for them, but we haven't got time to go into that more, and we look at that regularly on this committee anyway. I just wanted to ask Sir Chris, before I pass to Peter Grant and then Sir Bernard Jenkin. So Chris, if you could send us the monthly figures for PPE procured and distributed since the end of January, that would be very helpful. Is that something you can provide us with? There's a very useful...
Yes, I mean, I'll need to go and consult with our PPE team, but I'll look at what we...
Well, there's a figure 23 in the NEO report lists items, which would be, for ease of recording it, it would be helpful to go with those categories, if that's okay. So thank you.
Sure.
Thank you. We'll look forward to hearing from you on that. So Peter Grant, and then last word to Sir Bernard Jenkin. Peter Grant, MP.
Thank you, Chair. I just wanted to pick up on one of the recent comments about the fact that if this hadn't worked, if the precautions that we took in the middle of March hadn't worked, could have been facing, I think the witness said, potentially 1 million or more people being hospitalised. I may be remembering incorrectly, but I think in answer to a previous question about the difficulty in anticipating the demand for personal protective equipment, part of the answer was that this virus was landing more people in hospital than we'd anticipated. So unless I've completely misremembered the answer, it seems that we've got a virus that, on the one hand, puts far more people into hospital than we'd expected, and on the other hand, it's far fewer people. Is there a contradiction there, or is there something I'm missing?
No, there isn't a contradiction there. The numbers that Simon is quoting are what the reasonable worst-case scenario would have been if the actions that government and wider society took in terms of non-pharmaceutical interventions and social distancing measures hadn't worked. And the point where Simon may like to add, but that was the basis of our concern in March, was what would happen to the health service and elsewhere if those measures that we put into place did not cause both the flattening of the peak and then the decline that we have in fact seen. There's a separate thing which is which we didn't know at the beginning of the outbreak and have learned as we've gone on about where PPE is required due to the concerns about asymptomatic transmission. Those are two separate issues. But Simon, that is the point you were getting at, wasn't it?
So Simon, Peter Grant, is that Peter Grant? And then if you want to bring in Sir Simon.
Yeah, that then suggests to me that whatever was planned for in advance wasn't a reasonable worst-case scenario, was it? Was the planning that was done on the basis that it was something that would be as bad as or worse than the 1918-19 flu epidemic? Isn't that what a reasonable worst-case scenario should have been?
Well, you can have a go on that, Chris, if you'd like. Which is that if you look at the SAGE papers and the modelling which have now been published, you will see that quite clearly in mid-March there was a very dramatic shift in the forecast as to what might happen as a result of coronavirus, showing that potentially over 4% of the population might be hospitalised and 30% of those would require critical care. So the reason I say this was a very scary time, frankly, for everybody in the NHS is, if you look at the minutes published by SPI-M, the modelling group, on the 20th of March, so this was several days after we'd pulled the trigger on freeing up NHS capacity, they said, quote, "It is very likely that we will see intensive care capacity in London breached by the end of the month, even if additional measures are put in place today." Now, the government did put in place...
The problem is, Sir Simon, we haven't seen who this group is. We don't see these figures, so it's difficult for us to... We haven't seen these figures. If you could supply them to us, that might be helpful, but it's difficult when you introduce it in the middle of the meeting.
Okay, no, it's on the SAGE website and it's the 20th of March. I'm just pointing out that hindsight bias is a wonderful thing, and that's not what actually was going on at the time.
Right. Peter Grant, if you're complete, you finished?
Yes, I'm happy with that. Thank you, Chair.
Sir Bernard Jenkin, last word to you, Sir Bernard Jenkin.
I'll be as brief as I can, and I'm very grateful, having missed a certain amount of this meeting because of other duties. Forgive me for that, but I've been listening to the last hour and at least an hour and a half of this, and there is a sort of mismatch between being so ready for some eventualities and not ready for others. So when it came to beds and ventilators, how clear was who was responsible for ensuring that we had sufficient beds and ventilators?
Who's that to, Sir Bernard? To Chris.
Whoever wishes to answer.
To Chris Wormald.
Well, I mean, that was one of the clearest bits. I mean, the NAO report sets out the various responsibilities which in the NHS are very clear indeed. What I will say is the way we dealt with this crisis in the early stages was not to worry particularly about whose job was what. This was done as a joint exercise.
I think this is the interesting question, because I asked who was responsible, who was made responsible for making sure we had enough beds and ventilators.
Well, I mean, the provision of hospital care is quite clearly the primary responsibility of NHS England and improvement. What I'm saying is there is this was a giant cross-government.
I understand that, but I'm interested in what we are.
Hone your question.
About accountability and responsibility. Who equivalent, or what body was equivalent for the safety of people being transferred to care homes from hospitals?
Well, as I described earlier in this hearing, it's not a secret to anyone that statutory responsibilities in social care are spread between national and local government and individual providers. How we acted, however, was to essentially nationalise a lot of questions, and I've never denied that there is a considerable ambiguity in how social care is managed. We've discussed that with the committee before. What national government did within the powers available to us was, as I'd say, push the limits of what we could do in order to address the questions that you're raising. And as I said right at the beginning of this hearing, no one is denying that the challenges in social care because of those structural questions were particularly huge compared to the clarity we have on the NHS.
Yes. So, I mean, the creative question to ask at the end of this then is, what is going to change so that in future there is comparable clarity as NHS England has for beds and ventilators, for the safety of people in care homes and the provision of PPE in care homes?
Well, that's not a question I can answer. We operate within the laws and statutory framework that Parliament gives us. I think there is a considerable consensus. I don't think I'm straying beyond my civil service neutrality to say I think there is a considerable consensus in Parliament and elsewhere that there needs to be change. And I do think that our experiences with COVID heighten that need. But as I say, the approach we took at the beginning of COVID was to do the things that we thought were necessary, rather regardless of, well, I'm not going to say regardless of the statutory position, pushing the statutory position to its limit.
Sir Bernard, last point.
Tremendous sympathy for everybody on the front line of the NHS, but I imagine that it was pretty torrid in the Department of Health as well at the bad moment. So thank you for everything you did.
That's very kind of you.
Thank you very much, Sir Bernard. Thank you to our witnesses and thank you to the committee. Order. The committee is now over. Thank you.